Here we go. ECGs made easy. Why am I making this video? It's certainly not because I think the YouTube algorithm is going to like it. I have gotten a ton of requests from paramedic students, nursing students, EMTs that are thinking of going to paramedic school, even some EMTs that just want to know what they're looking at when they're looking at the cardiac monitor. So this is going to be a simple fundamentals breakdown of ECGs. So here's what we're going to learn in this video. We're going to learn all of the sinus rhythms, how the rhythms are organized, and how the ECGs work. We're going to have a follow-up video on the rest of the rhythms, but by the end of this video, you'll know what every one of those little squiggly lines on that cardiac monitor mean. Okay, so how do EKGs work? Well, let's get started with the electrodes. Now, there's this common misconception that an electrode's a lead, but an electrode is not a lead. The line between two electrodes is actually a lead. This is why 12 leads only have 10 cables, because some electrodes are used for multiple leads. Now, we just connected the right arm and the left arm, which forms what we know of as lead 1. If we take this other electrode and place it on the lower left leg, we create Einthoven's triangle, which creates two more leads, and that's going to be leads 2 and leads 3. Now, this next part's going to seem kind of arbitrary, but it's really important as we move forward, so please pay attention. This lead in the upper right arm is a negative lead. Meanwhile, the lead in the lower left leg is a positive lead. Now, this lead up in the upper left arm is both negative and positive. If we're looking at it from the perspective of lead 1, that lead is positive. If we're looking at it from the perspective of lead 3, that lead is negative. If we're going to understand ECGs, we need to understand how electricity moves through the heart. And it all starts with this guy. Up in the top right-hand corner of the heart is a group of cells called the SA node. Now, they come by all kinds of names. SA node, sinoatrial node. But for the sake of this video, we're going to call him the sinus node. Now, this is going to help you when we get to the naming part. After he fires, electricity goes cell by cell through the atria, and as it goes through those cardiac cells, they contract. And as a whole, the atria starts to contract and squeeze that blood in the atria down into the ventricle. Now that electricity travels on until it finds itself at this guy, the AV node. Now, the role of the AV node is actually slow down that electricity, because you can imagine if your atria and your ventricles were contracting at the same time, it wouldn't be very efficient. So it holds it for about 1/5 of a second, or 0.20 seconds. Then it releases it into this path right before it divides called the bundle of His. And that electricity continues on down into the Purkinje fibers. Now, this is how electricity travels through the heart. Notice it goes from the top right down. Do you see how it mirrors lead 2? That's why we typically monitor patients' heart rhythms in lead 2. It's not the only rhythm we can monitor, but it's the most common because it parallels with the overall average direction of the electricity through the heart. So now what's the difference between the negative and the positive electrode? Well, let's get rid of this guy for a second. As electricity moves towards that positive electrode, it creates a positive deflection on the EKG. That's because it's heading towards a positive electrode. Let's use the hypothetical example that the electricity is moving backwards through the heart. If it were to move towards the negative electrode, it would create a negative deflection on the EKG. Now, this yellow line is what we call a vector, and that's just terminology for the average direction of electricity. So what do I mean by vector? Well, I'll give you a brief explanation. However, this one specific topic would warrant a video all on its own. Now, you don't technically need to understand vectors to understand EKGs, but I feel like the why is important. So you're not just memorizing little squiggly lines on the monitor, you really understand what's going on. So we're going to use an example of a 911 call. So you get called to Miss McGillicuddy at 123 Easy Street. You arrive on scene, you load her up, you realize, oh, She's critical and unstable. We need to get her to the hospital. So, you and your partner plot a path to the hospital. You've been in the zone for a while, you know the district, and you know the best route there. Get her loaded up, and you travel east and then south for a little bit, east for a little bit, south, east, south, and you arrive at the hospital. To get Miss McGillicuddy to the hospital, we never traveled on a road that went southeast. We traveled east and we traveled south, but our overall average direction was southeast. Well, the heart is the same way. Even though that electricity travels in different directions at different parts of the heart, its overall average direction is southeast. Now that we understand how electricity goes through the heart, let's go through it one more time, but let's see what it looks like on the cardiac monitor. Electricity starts in the SA node and travels through the atria. This produces the first wave in a cardiac cycle, and it's called the P wave. Then it makes its way to the AV node, which holds it long enough for those atria to contract and push that blood down into the ventricles. Then it continues on down into the ventricles, and that produces what we call the QRS complex. And then at that point, the heart resets and gets ready for the next round, and that's called the T wave. To identify rhythms, it is an absolute must that we measure the amount of time it takes electricity to get through certain parts of the heart. So let's get rid of this guy so we have some room to work. Now, the first thing we want to measure is the PRI. The PRI is the segment of time from the very beginning of the P wave to the very beginning of the QRS, and it should be less than 0.20 seconds. The other thing we want to measure is the QRS complex. This is from the beginning of the QRS complex to the end of the QRS complex, and it should be less than 0.12 seconds. Now, how do we measure time? Well, we use the EKG paper. 5 of these large blocks equal 1 second. So if 5 of those fit into 1 second, one individual block equals 0.20 seconds. Now you'll notice inside that larger block are 5 smaller blocks. Each of those 5 smaller blocks is worth 0.04 seconds. So now let's carry this over to our PRI and our QRS. Our QRS needs to be less than 0.12. Well, if each small block is 0.04, that means we need less than 3 small blocks. So we carry it over there, and looky there. The QRS complex is less than 3 small blocks. That's what we call a narrow or normal complex. The other unit is the PRI. It's obviously 5 small blocks, which in this case, the PRI is less than 5 small blocks. So both of those would be considered normal. So quick recap, we understand what the P wave is. It's electricity that starts in the SA node that travels through the atria. The PRI, or that flat segment after the P wave, is where that AV node is holding that electricity, and the QRS complex is the electricity traveling through the ventricles. So let's move on. How do we pull rate from an EKG? Well, let's take a look. We start with the EKG paper. That's what we've been using to measure time thus far, and we know each of those large blocks are 0.20 seconds, and 5 of them equal 1 second. Now, look at these tabs at the top of the EKG paper. Every EKG paper I've ever seen has those. They have them in different increments. Some of them are 1 second. Some of them are 3 seconds, like this strip. Some of them are different sizes, between 3 and 6 seconds. But every EKG paper I've ever seen has those. So there's several different methods of pulling the heart rate from the EKG strip. The method that I'm going to show you is the simplest, but it's the least accurate. But we're not really worried about accuracy at this point. We're not trying to get the exact heart rates. We're just trying to get the heart ranges. So if we know that 5 blocks is 1 second, 15 blocks must be 3 seconds. And what we want to do is we want to count up to 6 seconds. So we count the number of complexes in a 6-second strip and multiply that number times 10, and you get the heart rate. Now, like I said, there's other methods that are more accurate, but they take a little bit longer. This method is very quick, but you're obviously going to always end up with a number that's divisible by 10. Now, let's throw a QRS complex in here and go ahead and practice with this. So we got a 3-second strip, and we need to count for 6 seconds. So if we count these complexes, we got 1, 2, 3, 4, 5, 6, 7 complexes. Providing this was a 6-second strip, that would be 14 complexes. 14 times 10 is 140. So this patient would be tachycardic. So the other thing we need to be able to pull from this EKG strip is the regularity of the rhythm. Let's get rid of all this stuff and let me show you an easy way to figure out how regular a rhythm is. Take a piece of paper and above the 2 QRSs, put 2 little hash marks with a pen or a pencil, and then just move that paper down that EKG strip and see if those lines fall onto those QRS complexes. If they do, the rhythm is regular. If they don't, it's irregular. Now, there's 2 different types of irregular rhythms. There's irregular, where there's absolutely no pattern to it, or there's irregular, where the rhythm as a whole has a pattern, but QRS to QRS to QRS doesn't necessarily line up all the way across the strip. If it were converted to sound, it would sound something like this. You see how there's still a pattern of 3, break, 3? There's irregularity in between the actual QRS complexes, but the strip as a whole still has a pattern to it, so it's classified again as regular, irregular. So now we have everything we need to know to identify a rhythm, or the 5 questions that you ask. We know how to get the rate, we know how to figure out the regularity, we know that the P waves is electricity beginning in the SA node and traveling through the atria, and we know that that's that first wave in the cardiac cycle. We know how to measure the QRS complex and the PRI. So let's take a look at how rhythms are classified, and then we're going to use these 5 questions to identify every single rhythm that the heart can generate. So what's up with the EKG names? Well, they're not arbitrary. There's a rhyme and a reason, and we're not going to go over every name, but I'm going to show you how to break down the names of each EKG rhythm, the origin of the impulse, and a rate. Now, when I say rate, it's not the exact heart rate, and this doesn't apply to every single rhythm, but about 90% of the rhythms will give you a heart rate range. And if you combine that heart rate range with the origin of the impulse, you get the rhythm. For example, the things that start here are sinus or atrial rhythms. Impulses that start here are junctional. Blocks are a conduction problem, but we're going to cover that in the next video. And then anything that starts down here is considered ventricular. Now, this is how the series is going to be organized. We're going to go over all the sinus and atrial rhythms today. The next video is going to be blocks and junctional, and the video after that will be ventricular rhythms. Let me give you an example of what I'm talking about. Let's say that we have an impulse that initiates in the sinus node. Well, the origin of the impulse is sinus. Now, let's say that the rate is 80. The names are based off of the rate name, and the rate is 80, and normal is 60 to 100. So that is normal. The rhythm is normal sinus rhythm. It's saying it initiated in the sinus and the rate is normal. You want to try some more? All right, let's try some more. Here we go. Origin, rate, and rhythm. All right, so for our first example, we have a impulse initiating in the sinus node. We have a rate between 60 and 100. We just went over this one. What's the rhythm? You're right, Normal sinus rhythm. Okay, well, let's try another one. Another impulse that starts in the sinus node. The rate is greater than 100. So what's the name for a heart rate greater than 100? Tachycardia. So what's the name of the rhythm? You got it. Sinus tach. Now I'm going to pause on this next one because I want you to try to do it yourself. We have another impulse originating in the sinus node. This time the rate is less than 60. Go ahead. You got it. Sinus bradycardia. Now let's go back to EKGs and see what these look like on the cardiac monitor. Hey, look at that. We have a strip, and you guys now know enough to be able to read this. So let's apply those 5 questions, the measurements, and all the things we've learned to actually identifying this strip. We'll start with the rate. Well, we got a 3-second strip because we have the 2 notches at the top. And we got 4 complexes in that 3-second strip. So we know we want to double that. That's going to put us at 8 complexes. So our rate, we're going to put at 80. Now, regularity. You remember how to check that? Let's pull out our piece of paper. Check. Looks regular. I'm good with that. Now, are the P waves present and upright? When we're checking the P waves, you don't have to measure every single P wave, but some of the rhythms that we're going to learn about later, you identify with the P wave and the PRI. When you're looking at a P wave, make sure you're scanning the whole strip to make sure they all kind of look uniform. And when it says upright, what we mean by upright is it's going in the same direction as the QRS complex. If the QRS complex was negative, then the P wave should be negative. But we'll take a look at this P wave. All of the P waves look pretty darn similar. It is going in the same direction as the QRS. So we're going to say, yeah, it's present and upright. Now we got to measure the QRS. So let's take a look at that. Don't get hung up on the exact fraction. I'm going to call that 2.5 squares. As long as it's under 3 small squares, we're good. In future videos, we'll talk about wide complexes, what causes them, and what's going on in the heart. But this guy looks narrow, so we're going to call him 2.5 squares, right? So that'll put him at 0.10. And now we got to measure the PRI from the beginning of the P wave to the beginning of the QRS. So obviously the atria fired. PRI looks like it's right at 4 squares. So we're going to call that 0.16. We'll put that up here. So the rate is normal. The regularity is regular, which is normal. The P waves are present. They're upright. We got one for every QRS complex. My QRS is less than 0.12 and my PRI is less than 0.20. Everything on this looks normal. There's only one rhythm that meets that criteria of all 5 of these questions being normal, and that is normal sinus. Now let's see what we have next. Okay, so what do we have here? Feel free to pause the video and try to figure it out on your own, but I'm going to walk through it kind of slow, but I want to give you time to be able to determine what kind of rhythm this is on your own. So as far as rate, we have 7 complexes in a 3-second strip, so we know we double that, so that's 14. And we add a 0 to the end of that, so the rate we're going to call 140. Now, regularity. Let's pull out our handy dandy piece of paper, see if it's regular. Yep, looks good to me. All right, I think we can call that regular. So the only thing abnormal at this point is the heart rate. Now let's take a look at the P wave. Okay, well, P wave's upright. It looks pretty uniform with the other P waves on the strip. Not seeing anything alarming, so we're going to say, yep, P wave's present, upright, and we have one for every QRS complex. Now let's go ahead and measure that QRS. Oh, looky there, we have about 2.5 small blocks again, so we're going to call that 0.10. We'll put that up there. And now let's measure the PRI. Look at that. 4 small blocks, so it's 0.16. Now is your time to shine. So the only thing abnormal with this particular strip is the rate. We know that it's sinus because we got a P wave with a normal PRI. We know it's regular. So that means this rhythm is, hopefully you said, sinus tachycardia. All right, let's try one more. Okay, woo, that's a scary one. All right, so we have 2 complexes on a 3-second strip. So we have a total of 4 complexes. So our rate is the scary low number of 40. Let's see if it's regular. Uh, well, we only have 2 complexes. So in this situation, what we got to do is just extend out the strip and then continue marching that down. Yep, he looks regular. So we'll call him regular. P waves, they look all identical to this one. I'm not seeing anything alarming or any drastic changes in shape. They're in the right direction. Every QRS complex has a P wave, so we're just going to say yes there. Let's measure that QRS complex. Looks pretty narrow, which is a good thing. I'm going to call it 2 small blocks, 0.08. So we'll go ahead and put that there, and then we'll measure the PRI. PRI is a little smaller too on this one. It's going to be 0.12. So 3 small blocks. So now the regularity is normal. P waves are normal. QRS and PRI are normal. The only thing abnormal is the rate, and it's slower. So we have a sinus rhythm with a slow rate. So we call that sinus bradycardia. I know we've been harping on these 3 rhythms throughout the course of the video. So let's move on and learn about some other rhythms that originate in the atria. Here's a new rhythm that we haven't talked about. And really, the rhythm isn't the problem. It's a single beat. And let's look across the strip. Do you notice the beat that looks different? You notice how the QRS complex is about the same shape, but the P wave is different. Why is that? Let me break that one down, but we're going to have to go back to Einthoven's triangle, and then we'll come back to this rhythm. So we know that normally the electricity in the heart moves from the top to the bottom, and it hits that positive electrode and creates a P wave. That odd beat that we were looking at is called a PAC, or premature atrial contraction, and it's when one part of the atrium becomes irritated for a variety of reasons, and it fires off and kind of temporarily, just for a single beat, takes the role of the SA node. So what happens when this fires off is it hits that positive electrode at a different angle, and it gives it a different shape P wave than you would get when it's coming from the SA node. Now, sometimes it's unifocal or just coming from one particular spot, and then other times it's coming from multiple spots. And every time it hits that electrode from a different angle, it's still going to produce a positive upright P wave, and the PRI should be still within normal limits. But the P waves are all going to be shaped differently. But we know it's originating in the atria because we have that P wave. It's before the complex, it's upright, the PRI is normal. So now let's jump back to that rhythm. And we're going to identify the rhythm underneath it, and then we're just going to call it with a PAC. So our rate, we're not going to count that single beat as a rate because as far as we know, it's just one individual beat. Multiplying the numbers like we have been would just give us a false heart rate. So we got 4 regular complexes. We double that for our 6-second strip. That gives us 8. So we got a rate of 80. Now, regularity. Let's check. We're going to skip over that beat, and we're going to see if it's regular aside from that beat. It is regular. The underlying rhythm is regular. That one beat throws it off. So instead of calling it regular, we're going to call it regular irregular. Now, are the P waves present upright? Yes, they're all present. They're all upright, but they're not uniform. So we need to acknowledge that so we can identify this beat. This P wave looks like the rest of them, and it meets all the criteria. So we're just going to say yes, but not uniformed. But what about the other P waves? Well, let's take this P wave, for example. It looks normal, upright. It matches the rest of the P waves with the exception of the one with the PAC. So we're going to go ahead and say the P waves are upright and present. So what we're doing here is we're actually trying to identify the individual rhythm, and then we're going to identify the actual beat. So let's measure that QRS. That looks like it's about 2.5 small blocks. So we'll call that 0.10. PRI, that's 4 blocks again. So 0.16. We'll put that in there. Since we have a regular rate of, so what we're going to call this, since we have a regular rate of 80, and all the other criteria are within normal limits, is we're going to call it a sinus rhythm with a PAC. So in this rhythm, that's an individual beat, but the same phenomenon can happen and it can actually override the rhythm. Okay, so here is a good example of it, but I will say this rhythm is relatively rare in the field, but we still need to know it for National Registry or on the off chance you come across it. So let's follow those 5 questions the same way we have been. We got 7 complexes there, so we'll double that, 14. That gives us a rate of 140. Let's see if it's regular. It looks good. Looks good. Great. So we'll call that regular. The P waves now. The P waves are all shaped differently. They're certainly not uniform. They are present, they are upright, but every P wave looks different. The same phenomenon that was going on with the PAC is going on in this rhythm. We're just getting impulses from different parts of the heart, but they're all originating in the atria. We're getting atrial contraction with it. They're just producing different shaped P waves. So we're going to say that they are, but they're ununiform. Now, let's go ahead and measure our QRS. We got a QRS 2.5 small blocks again. So that's going to be 0.10. Then let's measure the PRI. We're at 4 blocks again, 0.16. The rate's elevated, right? So that's off. So normal sinus rhythm out the window. Regularity, it is regular. The P waves is the hallmark of this rhythm. The P waves are there, but they're not uniform. And the PRI and the QRS are both within normal limits. I'm going to go ahead and tell you what it is. This one has kind of a cutesy little name. It's called a wandering pacemaker. And I think that makes sense. The problem with this name is it doesn't include the rate. So normal sinus, you don't really need to include the rate in the description of it. Since the name of this rhythm doesn't give you an indication of the rate, when you document this, it should be a wandering pacemaker at a rate of 140. Let's see what we have next. Now, this rhythm, unlike the last one, is one that you're going to commonly come across in EMS. And at a quick glance, even if you have no training, you probably see a few things off. So let's follow those 5 steps and see where it takes us. Well, we have a rate of 7 complexes times 2, which is 14. So we end up with the rate of 140 again. Regularity, let's check that. It does not appear to be regular at all. So we're going to go ahead and call this rhythm irregular. Matter of fact, we're going to call it irregular. The P waves present and upright. There is a lot of squiggly lines, but none of them that would really constitute a P wave. So we're going to say no. The QRS complex is, yeah, we're good there with 2.5 blocks again. And then we're going to check the PRI. Well, how do we measure the PRI without a P wave? So we don't have a PRI. Now, this rhythm is called atrial fibrillation. So let's take a break from the rhythms and talk about how atrial fibrillation works. In atrial fibrillation, you have so many groups of heart cells that are trying to take the job of the SA node that about 300 pulses a minute are going through the atria. That's more than the AV node can keep up with. So it allows what it can get through. There's way more stuff going on, and the atria end up just fibrillating, and they don't actually get the chance to contract. And because the AV node's getting hit with so many impulses, these rates tend to be on the fast side. Now, it doesn't have to be fast, but most of your AFib patients are going to be fast. But the hallmark is the irregularity. That's because of these 300 pulses, the AV node is grabbing different ones every time. So that the timing from the atria down to the ventricles is constantly fluctuating. So their heart rate is irregular. You're not getting a P wave because you're not getting contraction of the atria. You're just getting that fibrillation of the atria. Now let's move on to the next rhythm. So this is a pretty uncommon rhythm in the field, but it is very, very noticeable. Notice those P waves right off the bat. Now this rhythm is atrial flutter, and it's notorious for having those sawtooth P waves. Those are P waves, but you have 2 or 3 or even 4 per QRS. Matter of fact, when you document this, you're going to document how many P waves you have to QRSs. So let's go ahead and work our way through the rhythm. We got a rate of, looks like it's just barely 120. So let's see if it's regular. We'll pull out our handy dandy paper. Yep, looks regular. We can call that regular. Are the P waves present and upright? Yes, but there's 3 P waves to every QRS, creating that sawtooth pattern that we're looking at. So we're going to say yes, but we're also going to add a 3-to-1 ratio. Now let's check our QRS complex. Look at that. It's a little narrower than the last few we've had. That's 2 small blocks. So we're going to call that 0.08. And we'll check our PRI. That P wave just merges right into that QRS. So we can't really document a PRI. But this is atrial flutter. And the hallmark of atrial flutter is those sawtooth P waves. Okay, so what do we have here? Well, this is a completely new rhythm. Let's start with the rate. We got 1, 2, 3, 4, 5, 6, 7, 8 times 2. So we got a rate of 160. This cat is cooking. So let's check to see how regular this rhythm is. Well, looks pretty good. We'll call that regular. So are the P waves present and upright? Well, yeah, they are present, but you can see where they're merging into that T wave. That's very common in these super fast rhythms because as soon as the heart is reset, it starts over in another cycle and you start getting this merging or that camelback between the T wave and the P wave. But they are present, and there is one for every QRS. Now, let's measure the QRS, shall we? And it looks like we are really close to 3 small blocks. I'm going to call that 2.75. Again, don't get hung up on the exact size, as long as we're under 3, which it is definitely under 3. So we'll call that 0.12. And that's just because we rounded up. As long as we're less than 0.12, we're good. But we'll go ahead and call that 0.12. Now we'll measure that PRI. It's pretty short, and that's very common in these rapid rhythms. So 2 small blocks, so we're looking at 0.08. Now, the rhythm you're looking at is actually kind of a trash can term for a lot of different rhythms. And there's a lot of different causes. It's called SVT, or supraventricular tachycardia. Now, pay attention to that name, supra, above the ventricles. Now, there's a lot of causes for it. It shouldn't be mistaken with sinus tach, and I'll kind of break that down in a little bit. But this is different than a chronotropic response to exercise or hypovolemia. So to diagnose these patients with SVT, we got to take a good look at their history. If somebody's at the gym and has a heart rate of 160, that's acceptable. If somebody's blood pressure is starting to decrease, and this is again a chronotropic response, that's acceptable. But if they were sitting there watching Jeopardy, well, that 160 starts to seem a little fast. Another little tool you can use is your maximum tachycardia. Now, this isn't an exact number, but it's a roundabout. And you take 220 minus the age, and that anything above that number, if you don't have a cause for it, is probably due to SVT. So let's take a look at what's going on in the heart. Now, a common cause of SVT is a looping of the electricity through the atria. So an impulse is created and it works its way down to the AV node, but in the meantime, another impulse is created. And they start circling through the atria. And as they circle through the atria, they're ringing the AV node, and the AV node is sending out as many of those beats as they can. This creates those super rapid rates that we see in SVT. Now, SVT is a lot more complicated than I'm explaining here, but now at least you can identify the rhythm. Just remember to differentiate between SVT and sinus tachycardia. You need to incorporate the patient's history. We did it, and it wasn't that complicated, was it? We went through all of the rhythms, or at least all of the common rhythms that are initiated in the SA node and the atria. In the next video, we're going to cover junctional rhythms and AV blocks. But I've really enjoyed making this video. Please give me some feedback before we make that next video. Let me know if there's something you like or something you didn't like. But until then, be safe.